onto our stream right now, and we are live. So, hello, all the humans. Welcome to the Humanist Society of Greater Phoenix Sunday speaker event. Remember, if you like our content, please press the like button, subscribe, and get more of our content. Or join our Patreon, become a member, and volunteer. Today's presentation aligns with our values of critical thinking. As we are bombarded with a constant stream of information, it can become challenging to decide what is accurate and true. Responsibility. Every day, each of us makes choices. These choices, large and small, all have consequences for ourselves and the world around us. And altruism. The collective welfare of our communities and society depends on the welfare of each individual person. Today, we have Will Humble with Evidence and Ethics of Vaccine Prioritization. Will Humble is the Executive Director for the Arizona Public Health Association. His 30 years in public health included more than 2 decades at the Arizona Department of Health Services, where he served in various capacities, including the agency director from 2009 to 2015. Most recently, he served as a health policy director at the University of Arizona from 2015 to 2017. He continues to be involved in health policy in his role with AzPHA and as adjunct faculty with the University of Arizona's Mel and Enid Zuckerman College of Public Health. He received a Bachelor of Science in Marketing from Northern Arizona University, a Bachelor of Science in Microbiology from Arizona State University, and a Master's in Public Health from the University of California, Berkeley. He was awarded an Honorary Doctorate from the University of Arizona in 2015 for his career commitment to engaging partnerships between academic and executive public health. Mr. Humble strongly believes in the use of evidence-based health policy as a means to improving health outcomes and strives to lead and manage with emotional intelligence, for which I am profusely grateful. Please give a big HSGP welcome to Will Humble. You are muted, Will. Well, he's coming. I see him. You're muted, sir.
I'm going to move closer to my internet connection because it says unstable, which is a problem. Okay. It could be that we have too many people on right now in the house. Sorry about this. Okay. So my internet stable connection is unstable. So during my presentation, so I'm going out on the front porch.
All righty, sir. Please stand by.
Okay, I'm closer. Oops.
We can hear you just fine, sir.
Okay, I'm closer now, and hopefully we'll have a better experience
Okay.
internet-wise. But there's other people on my Wi-Fi at home, so that's part of the thing too. Okay, so I'm going to share my screen here. How's it look?
Looks good, sir.
Okay, so today there's a few things I want to cover today, and I'll how come it's not advancing? Here we go. Here's some of our objectives for this morning. I want to give a background and sort of an overview of the various vaccines that are under development. I want to touch on how the FDA makes decisions, for approving and authorizing vaccines. I want to talk about a report that the National Academy of Medicine put out a couple of months ago. And the goal for that report was to have an objective and evidence-based review of making recommendations for prioritizing the early vaccine. And then I want to get into a discussion of the ethics of vaccine prioritization, the decisions that have been made thus far by the state and county health departments, and how that matches up with the epidemiology and risk factors for COVID-19. And then finally, while I didn't put this on as an objective, I mean, we made the decision to do this presentation back in November, I think. But one of the things that you all may want to talk about is what is the inside scoop for why the vaccine rollout has been so ineffective thus far in Arizona. And I could give you a perspective, an inside view of some of the nuances of why that has been happening. I can't forecast whether those will get straightened out in the near term, but we could talk about what some of the current problems are. So I'll try to run, and I'm going to run through some of the broad-based stuff pretty quickly so that we can get into some of the discussion points. And before we got started here today, I talked to Ron, and he said that what we'll do is as you have questions, if you have questions or comments, go ahead and put those in the chat box, and Ron will then, cue me, and we'll have a little discussion. So, well, the way I like to do things is, as questions come up during the presentation, ask them then. Don't wait to the end. So, if you have something that's contemporaneous, let's address it right away.
And if you're comfortable raising your hand in the interface, I will call on you, or type your question and I will read it. So
this graph is a little bit about herd immunity. So you've all heard the words herd immunity by now. And that's actually what we are trying to achieve. But the ethical way to achieve it is through vaccination, not natural infection. Back in the, prior to the 19th century, prior to the advent of vaccines, that herd immunity is how, epidemics resolved themselves. It just infected so many people that eventually, there was a critical mass of people with antibodies, and the vaccine really never spread after that. With the advent of vaccines in the 20th century, we can now achieve herd immunity through vaccination. And that's the desirable way to do it, because that's how you save lives. And so that's ultimately our goal, public health goals, to get to herd immunity, but do it through vaccination primarily. But there's actually going to be two ways that we really, in the end, achieve herd immunity, and it's going to be through natural infection, people who get infected with the SARS-CoV-2 virus, combined with the people that are vaccinated for the illness, and both of those combine to get you to herd immunity. Now, we don't know what the herd immunity threshold is. By the way, herd immunity is just the percentage of the population that you need to have antibodies in order to stifle the vaccine replication. In other words, every time the virus infects somebody, its reproductive goal is to infect somebody new and have them infect somebody new so that the virus can replicate itself. The more people you get to have antibodies to the virus, the fewer opportunities the virus has to infect a new host. And eventually, once you have enough people with antibodies, the virus is no longer able to replicate itself in perpetuity, and it ends up hitting too many dead ends. In other words, dead end being a host that's either vaccinated or has antibodies because they were infected with the virus and recovered. We don't know what that threshold is, but it could be somewhere around 65, 70% of the population. We're going to achieve it in two different ways. One, through natural infection. Given Arizona's situation and how poorly we are doing in terms of slowing the spread of this virus in our state, we're already at about, I would say, about 22 to 25% of Arizonans have been infected with the virus and recovered. We need to get to 65 to 70% for herd immunity. So what that means is we need to get a little more than half of the population to have antibodies to this virus through vaccination. And that is really a combination of both the vaccine effectiveness and the percentage of the population that you're able to vaccinate. When I put this PowerPoint together a couple of months ago, it was before the phase 3 clinical trials had been finished. And to give a realistic expectation of what the effectiveness of the vaccines might be, I put in a 70% effective as an estimate. But it turns out that both the Pfizer vaccine and the Moderna vaccine in the phase 3 clinical trials suggest that they are more than 90% effective. And that's really good, because the more effective the vaccine is, the fewer people that you need to vaccinate to get to herd immunity. So this next, basically my estimate is that if we are able to vaccinate about 4.5 to 5 million people, and if it's true that Moderna and the Pfizer vaccines are both more than 90% effective, that combined with the fact that about 20% of the population has been infected with the virus or recovered, would mean that we could get to herd immunity. So we got 7.2 million people in Arizona. If we could vaccinate 4.8 of them, I think we could get to herd immunity. Now, we could talk at the end about the challenges, so at least so far, with those vaccination programs. But I want to touch on vaccine safety a little bit here too. There's basically a 3-phase process that we use in the U.S., which is also used in most of the most of the world, to determine whether a vaccine is both safe and effective. The first is phase 1 trials, which are just the very beginning trial where you're really mostly looking at vaccine safety. Well, first there's preclinical trials, which is animal studies and so forth. You get into phase 1, that's a small number of participants. You're looking mostly at vaccine safety. So you're looking for side effects, adverse events, and so forth. And then if that's successful, you can move into phase 2, usually several hundred participants in phase 2, where you're looking at both the safety and the effectiveness of the vaccine. And then finally, you go into the very big, large phase 3 trials, which we'll go into a little bit more detail on. And those are usually tens of thousands. In the case of these vaccines for COVID-19, the phase 3 trials have had between 30 and 40,000 participants, some of whom get the actual vaccine, and then some of whom get, of course, the saltwater placebo. And then you measure the differences as those people go out into the world and conduct their daily affairs and business, and then you compare the outcomes between the people who have, who got the actual vaccine and those that got the saltwater challenge. That data is then submitted to the FDA for review. And as you have both know, or everybody knows, the FDA has authorized, and we'll get into the difference between authorization and approval, but authorized at least Moderna and Pfizer's vaccines so far. We'll get into some more detail there. I already talked about this slide. So I think I'll press ahead, but you get the idea. Phase 1, phase 2, phase 3, it's a phased approach. The final phase being this placebo-controlled randomized trial. As I said, 30 to 50,000 participants have been in those trials. And this is the time frame for the phase 3 trials. So once you begin your phase 3 trial, it takes about 2 to 2.5 months. If everything goes perfectly, you're looking at about 2 to 2.5 months before you can have the kind of data that you need to determine whether a vaccine is both safe and effective. Out of this whole the Gantt chart here, you see the recruitment phase is actually the most challenging and time-consuming part of the clinical trial. That's the part where you're working through identifying people to participate in the clinical trials. And one of the things that makes it challenging is that in order to have a good clinical trial, you have to have good representation of different age groups, of different ethnicities, of people with different pre-existing medical conditions, people of different income brackets, and that's easier said than done. And so many of you, I bet you some of you that are on the call today actually volunteered for one of the clinical trials, and perhaps one of you have participating. And if somebody on the call today is participating in a clinical trial, it might be interesting to talk to one of you as we go through this. So let Ron know if you participated. I volunteered to participate in the Moderna clinical trial, but I wasn't selected. And part of that might be that I'm a middle-aged white guy with no medical conditions. So I'm not a super desirable person for the clinical trial because there's nothing unique or special about my condition. I don't have diabetes or asthma or really anything. And so when you volunteer for the trial, you answer a whole host of questions about those sorts of things. And ultimately, I wasn't selected, but I would have liked to have had that experience and participate. But this is why this is one of the things that took so long. Well, actually, it's rocket speed. I mean, the vaccines were developed very quickly because of the amount of resources that were put into it globally. But the timeline here is why it takes 90 to 100 days to finish the clinical trial work before you can submit that information to the review committees. So here are some of the efforts that have some of the players, I guess I would say, that have gone into the vaccine development process. It has been from the very start a collaboration between the U.S. federal government, Congress, who funded these activities, and public-private partnerships with the various vaccine manufacturers. There are a number of federal agencies that are involved with the process. Of course, the vaccine manufacturers. The U.S. Department of Defense has been actively engaged from the very beginning. That was a choice that the Trump administration made to engage the Department of Defense. That's a new thing. That's not an organization that's usually involved with vaccine distribution, although I could see the strength that they have is that they're good at logistics. And so to the extent they can add on logistics, that they may be a valuable partner. We'll see at the end of this whether it turns out that was a good choice or not. Obviously, CDC and the heavy hitter here is really the U.S. Food and Drug Administration. It says agency here. I got to change that. It's administration. So there's two key areas where I think the federal government did a good job in terms of facilitating fast development of these vaccines. Number one is that the federal government set up a partnership in which the vaccine manufacturers could receive federal funds to help finance the research and development of the various vaccines. This helped a lot because the way vaccine manufacturers and corporations usually behave is that they invest, their chief financial officers are making a lot of the decisions around what they invest in research and development, and depending on how much they invest in R&D, that can really impact how quickly the development of the vaccine is. In this case, for the companies that participated, Moderna participated. Interestingly, Pfizer did not participate. The federal government was paying for research and development. Now, the companies had to agree to certain things around data transparency and some other things in order to qualify for that financial aid. But it did accelerate the process significantly. Another key decision, perhaps the most important decision of all, was that the federal government told these vaccine manufacturers that they would buy vaccine that the companies were making during the phase 3 clinical trials. And if it turned out that the vaccine didn't work, or if it was unsafe, the federal government would pay for the vaccine anyway. Well, that helped a ton because the chief financial officers of these companies were like, look, we can make the vaccine during the clinical trial, scale it up, put it in freezers, and even if it doesn't work, we're still going to be made whole and probably even make money. So so these companies then have been making the vaccine during their phase 3 clinical trials. And that's why you see, in Arizona, I think we have 400,000 doses combined between the Pfizer and Moderna vaccine in freezers right now in Arizona. And that's because those doses were made, in probably even September, but for sure October and November, well before the vaccines were authorized by the FDA. So that really sped the process up a lot. Again, basically by just taking the financial risk out of the system. Last bullet here is just highlights the fact that the FDA commissioner has the ultimate authority to determine whether a vaccine is safe and effective. There's our advisory committees that help to make that decision, but that's where the buck stops with the FDA commissioner. This is a little bit about some of the various vaccines. I just picked a few to put up on this slide. You see the asterisk there on the first two, which is the Moderna and the Pfizer vaccines. Something that you see where if you look on the slide and see the type, this is a very unique. These are both very unique vaccines. The first time ever that vaccines have been made using this process that focuses on messenger RNA as the mechanism for eliciting the immune response among folks that get vaccinated. In a nutshell, what this normal vaccines are, let's take like your influenza vaccines, for example, can be either live viruses that are attenuated. In other words, viruses that are made so that they're no longer pathogenic, but still elicit an immune response. So there are examples of many vaccines that use a live attenuated virus to elicit the immune response. Other vaccines are an actual virus it's a live pathogenic virus that's killed and then is injected into people, and the antigens on the surface of that virus will then elicit the immune response. These two first vaccines, Moderna and Pfizer, they use messenger RNA. So the vaccine itself is simply an injection of messenger RNA, which has it has the ability to get into your cells and then tells your cells to make the antigen that codes for the protein coat of the SARS-CoV-2 virus that causes COVID-19, and your body starts making the antibodies to those antigens. And so rather than being, a live attenuated virus or a killed viral vector, these two are messenger RNA, really innovative technology. I didn't put all of vaccines up here, but there are 11 vaccines that are in clinical trials right now across in different countries, including the United States. First two out of the box, obviously Moderna and Pfizer. The next one I expect to be the AstraZeneca vaccine. We could talk a little bit about that later. Just in terms of the trial characteristics, I think it's worth mentioning here that the Moderna trial is obviously I didn't say obviously, but it's a booster shot. So you get an initial dose and then another one 28 days later. The clinical trial was people 18 to 55 and another group of 56 plus. One of the things you notice there that the Moderna vaccine was not tested in kids. Same thing with Pfizer's vaccine. The trial characteristics is 18 to 85 years old. Again, no kids involved with that. And you'll see that across the board that all of the vaccines that were in initial clinical trials were not tested on kids, but did all include that all important 65 plus demographic, and we'll get, because that's the primary risk factor. Okay, I am going too slow. I'm going to have to start speeding up if we're going to make it. I'll just go quickly on this one. So one of the issues with these vaccines, the first two vaccines, are that they have very special storage and handling requirements, especially the Pfizer vaccine. That is leading in part to some of the slow rollout of these vaccines throughout the country. And I'll focus on two main things with the Pfizer vaccine. One is that after the vaccine is made, it needs to be stored at -70 degrees centigrade. That's -94 Fahrenheit. The freezer that you have at home is probably, something like 0 degrees, or excuse me, -15 degrees centigrade. These are not normal freezers. And so it's been challenging, to find entities that had pre-existing freezers that can hold the vaccine at 94 degrees below 0 Fahrenheit. That's been a challenge with the Pfizer vaccine. For the Moderna vaccine, that it has a little bit easier storage handling. You could see -4 Fahrenheit or 20 below C. That's just a normal, like commercial freezer. So you can, so the Moderna vaccine is a lot more flexible in terms of how it could be held. Another nuance with the Pfizer vaccine that's causing some troubles with rollout is that it comes in boxes of about 1,000 doses, 975 doses. And so if you're going to open a box of Pfizer, you need to be able to administer about 1,000 doses within a day or so. And so because this is valuable, obviously, product, you don't want to waste any of the vaccine. You have to use the Pfizer product in environments where you can do mass vaccinations. The Moderna is more flexible because it doesn't come in that 1,000 dose package. It comes in, I think, 100 doses, which is a lot easier to commit to within a short period of time. I already talked about this in the earlier slide, and I think I'll probably, in the interest of time, skip this one as well. So the first, one of the great things about the clinical trials for both Pfizer and Moderna is that both of them established, and both of these are peer-reviewed studies now, so these data have been published, that the Pfizer vaccine is more than 90% effective at preventing symptomatic infection with the SARS-CoV-2 virus. Moderna, their study suggested 94%. These are very impressive numbers. If you look at where we are every year with the influenza vaccine, it's more in the 60% range in terms of effectiveness. These are very impressive. And again, remember, this is the effectiveness at preventing infection. When it comes to preventing death, it's even higher than that. The 90% and 94% effectiveness data come from, number one, the initial dose, but then after 7 days after the booster dose, that's when they measure the effectiveness, or they begin measuring the effectiveness. And so very impressive results. And I think in part it might be because these first two vaccines are this new technology that uses messenger RNA. I think this is a standard that we can't expect to see from the future vaccines, but perhaps I'll be surprised. Most of us are expecting that the next vaccine out of the gate will be the AstraZeneca product, which is a collaboration between the AstraZeneca Corporation and Oxford University in England. That vaccine has been manufactured in phase 3. They have a contract with the federal government. There are millions of doses that have already been produced of the AstraZeneca vaccine. The United Kingdom has already authorized the AstraZeneca vaccine, and it has actually been deployed now for a couple of weeks in the UK. The company has not asked the FDA for emergency use authorization yet in the US. I believe they've completed their phase 3 clinical trials. So I'm not quite sure why they haven't applied to the FDA for emergency use authorization, but I think most of us expect the AstraZeneca vaccine to apply for that authorization shortly. One of the reasons why all of us in public health are anxious and looking forward to the AstraZeneca vaccine is because this vaccine does not require any frozen cold chain. It's refrigerated and stored at 2 degrees centigrade. So you don't even need to freeze it. So what that means is the AstraZeneca vaccine is great, will be terrific for regular clinical settings, doctor's offices, community health centers, a range of even firehouses. I mean, if you don't have to have that crazy cold chain, oh boy, it really opens up the possibilities of where you can deploy this vaccine. So I'm really looking forward to AstraZeneca being out and on emergency use, because it's just so much more flexible in terms of the ways that it could get out. You could just ship it to all kinds of doctors' offices all around the country, which would be just so much better than these mass vaccination clinics that we're seeing these days. Does somebody have a time check for me?
You are at 10:47. You have approximately 45 minutes till the end, 30 minutes until Q&A.
Okay, well, I'm doing better than I thought then. Okay, so let's jump into vaccine. Any questions so far before I start talking about vaccine prioritization?
Absolutely.
Okay.
So Paul Stapleton Smith asks, a healthy economy depends on a healthy community. Right now, we have neither. Worker safety committees that coordinate with public health departments and employers to keep workers and customers safe are being used across the country by our unions and the National Council for Occupational Safety and Health Expert. Can we develop and use worker safety committees in Arizona to assist our public health department programs?
Well, yeah, I think the answer to that is yes. Can we? Is it being done? Is another answer. I don't know to the extent that that's actually happening at some of the bigger employers around the state. Perhaps somebody else on today's event will have a better answer to that. The answer is yes, it could be. Yes, it would be valuable. Is it actually happening? I don't know the extent to it is happening or not.
And then I've got another question, 2 questions from Anna real quick. She keeps hearing that immunized persons may be able to spread COVID virus asymptomatically, yet the research shows 90% of those immunized don't get COVID. If they are testing negative, how would they spread the disease? Wouldn't asymptomatic spreading risk be limited to the 5% that don't get full immunity? And wouldn't antibody tests be a good indicator of whether an individual's vaccine worked for them?
That's a great question. And a lot of that we don't know the answer to. And in part, it's because of the nature of how the clinical trials are conducted. So if your clinical trial is looking, let's say you have a clinical trial and you have 40,000 participants. Let's say you're going to have half of them get the actual vaccine and half get the placebo. You send them both out into the world for their daily activities, and then you monitor them over time for how many in each of those groups end up actually contracting COVID-19. Then you have a clinical trial that looks at identifying people that were either clinically infected where they had symptoms and went on to get tested, or that were diligent and ran out there and got tested even though they were asymptomatic. And if your clinical, let's say your clinical trial included testing every single participant every week for COVID-19, then you could answer the question you just asked, which is, what's the asymptomatic component here? But the clinical trials that I know of didn't do it with that kind of rigor. It looked for, people who became symptomatic for COVID-19 illness and then use that as the data endpoint for effectiveness. So the more rigor you have in your clinical trial, the better able you are to answer the questions that you asked. And one of the key questions in that was that you asked, which is, do we know that the vaccines actually prevent people from spreading the virus who are asymptomatic? We don't know. We don't know. It's 94% effective, 95% effective, these first two vaccines, in preventing COVID-19 illness. But we don't know the component of whether there's other kinds of asymptomatic spread that are happening in which people don't get vaccinated. So that's why CDC, others in public health are urging people to continue to wear face coverings while they're in public, even after they've been vaccinated, because we don't have the answer to that question. Can they spread it even after they've been vaccinated and they're not symptomatic? My gut tells me that probably there's a very limited amount of that spread that's happening in post-vaccinated people. But it's one of the reasons we urge people to continue to wear a mask, along with the fact that, look, once you get vaccinated, and more people are going to be vaccinated here shortly, and more people have been infected with the virus or recovered, as those people recover and start going out into public, if they're not wearing a face covering, it kind of creates like community, like people are pissed off. Like, for example, one of my kids, he's 26, he's got Down syndrome. He was infected with COVID-19 and recovered, and because he's recovered from the virus, he's no threat to spread this virus to anybody. But when he goes out in public, we always ask him to wear a mask, and he's really good about it. Because then people will see that he's wearing a mask, even though, truthfully, if you've been infected and recovered, there's no epidemiological reason to continue to wear a face covering in public, but it's an important thing to show solidarity with the rest of us that you care. So I think this is going to be, by the way, an increasingly challenging thing, where people decide not to wear a face covering in public because they were infected and recovered and or had been vaccinated, and just feel like they can go out that way. But it's not like you have something on your forehead that said vaccinated or something. So anyway, I hit some of the answers to that, but not all of them.
Yeah, the other follow-up to that was, do we know whether it's only through aerated particles or touch surfaces through communicating COVID-19, and how does that affect people who have previously had it?
Yeah, great question. At the very beginning of this pandemic, you can remember everybody focusing on, the importance of face coverings, and there was a big emphasis on surfaces and hand washing. The more we have learned especially over the summer, the more we have discovered that airborne transmission is absolutely the dominant way that this virus spreads. I'm not saying hand washing isn't important, but what I do advise people in organizations is that if you have limited resources, focus on symptom checks, focus on face coverings, focus on ventilation. Those are your keys to mitigating spread within an environment. And do not waste money on these companies that will come in and bring spray machines in. They're spraying bleach or disinfectant on surfaces, because that's a waste of money. It was unclear back in March and April, but now it is so clear that aerosol and droplets are the dominant way this virus spreads, and that vigorous hand washing regimens and surface disinfection is a really negligible intervention. If you have money, buy masks. Don't buy disinfectants for surfaces. But hand washing is always a good idea for other public health reasons. But I'm glad you brought that up. It's dominated by airborne spread.
Okay, Perfect. I'm in the interest of time, I'm going to let you go on before I read the rest of the questions. We'll hold the rest of the questions for the next session.
Okay.
Next break.
So vaccine prioritization. So I got a few slides here to talk about, where we are and where we're going in terms of vaccine prioritization. Obviously, in the US at least, vaccines are available but scarce. That will continue to be the case. If the AstraZeneca vaccine is approved in January, that will change and we'll have even more. It won't be as scarce as it is. But there are really important decisions that need to be made, given that it's a scarce product that's life-saving. How should we use it? How should we use it? And so, so I was very pleased to see back in the summer that the National Institutes of Health and the CDC worked together to hire the National Academies of Science, Medicine, and Engineering, who I think have a very good reputation of not having conflicts of interest. They hired them to really dive into the details of the risk factors for this virus, look at the science and the epidemiology, and make recommendations for where the early doses of vaccines should go. And we'll talk about that in a bit. And that is what that report, and I've got a link to it here on the next slide, is really the key report that informed how the United States has been prioritizing early doses of vaccine. And let me go ahead and show you what the National Academy of Sciences, Medicine and Engineering recommended. And by the way, Ron, I'll send you this PowerPoint at the end so that you can have it if you want to post it up on the website or whatever. And each of where you see that things are underlined, that will actually go to the actual source documents. So if you click on that first bullet, you'll actually go to the National Academy plan for the equitable allocation of vaccine. It's a 300-page report, so it's kind of intimidating in that regard. But what they did was divide their recommendations into various tiers. I have some detail here about tier 1, and the next slide it'll talk a little bit about some of the other tiers. But this report recommended frontline healthcare workers and emergency service workers in category 1A. So that would be people who work in nursing homes, hospitals, home health, etc. 1B being older adults in crowded settings. That's folks in nursing homes and assisted living centers, etc. And then persons of all ages with comorbid conditions. That would be, COPD and other sorts of chronic medical conditions that put them at higher risk. So that's just in a nutshell what the National Academy put forward as the first part of tier 1. These slides are out of order. Hold on. Yeah, so I messed with this morning and I didn't have time to fix it completely. So this is a little bit of out of order here, but so you can see here, this is from the National Academy report in chapter 3, and it talks about phase 1A is the jumpstart phase, high risk workers, B being people in nursing homes, etc. Phase 2, they include, folks in high risk occupations, K-12 teachers, homeless shelters, people living in correctional institutions, prisons, etc. Phase 3, young adults, kids, workers, and at phase 4, everybody else. I'm pretty sure I'm in phase 4. But let me go back here. So how is that translated in Arizona? So this is, so So if you take the National Academy of Science, Medicine, and Engineering, and then look at what the Advisory Committee for Immunization Practices put together a couple weeks ago, and that I sent that link out. So Ron, you have that, which is the Morbidity Mortality Weekly Report that CC put out with their recommendations. You could see what the various phases are. So let's use this. So this is what Arizona is using to prioritize the early doses of vaccine. Most of our counties are still in category 1A, including Maricopa County. Maricopa County's transitioning to 1B starting Monday. And I think most of the other counties, including Pima, are going to begin vaccination within category 1B starting tomorrow. But category 1A, so those are the vaccines since December 15th, have been focusing on healthcare workers with direct patient care, with the idea being that staffing in hospitals has been a real critical control point for being able to treat people with the normal standard of care. And so that was the rationale for vaccinating healthcare workers. They did include emergency medical service workers. So this would be paramedics and EMTs in category 1A. And then my favorite group, which is long-term care facility staff and residents. This vaccination campaign, I think, is absolutely critical. I don't have any direct information about how effective this vaccine effort has been within nursing homes and assisted living centers. Perhaps some of you have family members that are living in those facilities and can say whether or not that's been successful in your experiences. But that vaccination effort has been a federal contract. So for healthcare workers, you saw the big giant mass vaccination clinics the last 2 weeks here in Maricopa County and other places in the state. That was really for healthcare workers. The people who live in assisted living and skilled nursing were being vaccinated and still are being vaccinated under a contract that the federal government has with Walgreens and CVS to actually go into those care homes and vaccinate the residents and staff of those facilities. So that's how it's really a bifurcated system for 1A. 1B is where we're headed starting next week, and that includes teachers, adults 75 years and up, adults living in congregate settings, and other essential workers. We could talk about the merits of that, and I think that would be a good discussion. Here's the thing about, and then you can see 1C is adults 85 or 65 and older, and adults of any age with high risk medical conditions. If I kind of have a beef with this, quite honestly, where I look, it's not that I'm against law enforcement or anything, but why in the world do you have law enforcement in 1B and you have adults of any age with high risk medical conditions and adults 65 and older in the next phase 1C, which is 1C is probably March. There's a million people in 1B in Arizona, a million people out of 7.2 million in our state, a million are in 1B. Look at this. Another kind of beef I have with this is other essential workers. So this is people who, let's say, work, nothing against people that work in grocery stores. I appreciate the work that they've been doing out there with the public, but they are prioritized ahead of people 65 and older, and people with, let's say, COPD and other high-risk medical conditions that might not be 75 years old yet. I think in general, they did a good job. If I was still in charge in my former job, Roxanne and I were long colleagues at the department, I would have probably put law enforcement in 1C and other essential workers into 1C, and maybe moved over adults, or probably left adults 65 and older in 1C. But that way you could focus on adults 75 and older and those in congregate settings during phase 1B. After all, they are the ones that are at the highest risk of being hospitalized, and which is a huge problem right now. And I got a couple slides about that coming up. But I'm not in charge anymore, and I quit my job voluntarily, so I could have been there. But I don't think I would have been able to work with our current governor. So this is, I just took a screenshot because this is the only way I could find this data today. But so this is the number of people in Arizona in the different categories. So so look at this. So the category 1B, you can see where 1B is here. Look at that. Adults 75 and older, 534,000 people in Arizona are 75 years and older in 1B. 227,000 people that work in either transportation, material moving, that means, you know, gas stations, auto shops, that kind of stuff. 268,000 people that work in agriculture and those sorts of things. You know, I don't have a beef with calling teachers and childcare providers essential workers in 1B, because the sooner we can vaccinate teachers, the sooner students can actually get in-person instruction. But I don't really see the wisdom of putting, you know, people who work in gas stations and stuff ahead of in this 1B group. And we could have a debate about that. That's just my personal feelings about it. I just think if you've got 1 million people in category 1B, you should be more focused and targeted. And my opinion is it should really be focusing on people 75 years and older. And why do I say that? It's what's happening in the hospitals. You can't see, because there's people on the right-hand side here, you can't see where the trend line is going. But this is a graph of current hospitalizations in Arizona with the orangish color. That's the number of people in ICU beds in Arizona that are there because of COVID-19. And you could see what's happening throughout the entire state is that, you know, our hospitals are filling with COVID-19 patients. And these patients are coming in certain demographic groups. And here they are. Look at the graph on the left. This is the deaths. The graph on the top is the COVID-19 deaths, death curve in Arizona. The first peak being in July and the current peak now. Deaths. So look at that, 65 plus age group. You know, the vast majority of deaths are coming, and hospitalizations for that matter, are coming from that 65 and up group. The next being 55 to 64. So it just seems to me that if you're looking at this from a perspective of how do we save as many lives as we can, how can we create an environment in the hospitals so that people with conditions other than COVID-19 are able to start getting treatment for their conditions again, people who need knee replacements, hip replacements, people who have a slow growing prostate cancer, for example. Those are all people that have been pushed out of the system. They're unable to get treatment right now because the hospitals are so crunched. Well, how do you solve that problem? Well, number one, you could do non-pharmaceutical interventions like close the bars, which the governor has no interest in doing, nor does our current health director. So there's a lot of things that could be done that are not happening. But if you're just going to look at purely from a vaccination point of view, look, focus on people 65 and up. I mean, it's not that hard. So in some ways, this is an editorial comment on my part, that I think we have overthought this in the United States with all these different priority groups. And perhaps a better approach would have just been, look, we get our healthcare workers with direct patient care first. Let's take care of that group quickly. There's only a couple 100,000 of those in the state. Let's do that. And then let's start going by age and work our way down the list, you know, by capturing those folks, because that's the dominant risk factor. But instead, we've inserted judgment calls about the fact that you work at a grocery store, or a nuclear power plant, or you work for APS or SRP. Those are all people that are categorized in 1B that will be getting vaccines before people, you know, 65 and up, 65 to 75 at least. So I don't know. These are tough decisions, and I don't want to really be too hard on them, but our European partners are really focusing more on age than we are with these judgment calls about what your job is, kind of thing, that we're doing in our country. So with that, I think we could open it up for the rest of the questions, Ron. Are we about timed out for that, right?
Yeah, we're good with that. So I'll go over some of the phase questions first, and then get into some of the previous questions. So, are you going to need to show proof of underlying health conditions to get into phase 1B?
Well, that would be phase 1C, because phase 1B, you would have to show, let's look at phase 1B, it's on the screen now. So you'd need to be able to establish that you were a teacher or you worked in childcare. So that would be your ID from work. You need, if you're law enforcement, I think they should be 1C, but they're 1B. Show your badge, I guess. 75 and up, then you would need an ID. So that would be your passport or your driver's license if you're still driving, or something else that shows you're 75. If you're an adult living in congregate setting, that's easy. But in 1C, adults of any age with high risk medical condition, that's a slippery slope, isn't it? I mean, so the answer is, I don't know. I don't know when we get to 1C, if you can show up, do the pre-registration, if they're going to ask you to show that, your insulin or whatever, that, that you've got diabetes. I don't know. I don't know how they're going to do that. Adults of any age with high risk medical conditions. Here's the thing about that. If you're too strict about it, then you slow the line down and you get the vaccine out more slowly. The more strict you are in terms of that, the slower it's going to go. The more you use the honor system, the more people are going to cheat. So and get ahead in line. So I don't have a clear answer for how you deal with that.
Okay.
But I don't know the answer to the question, nor do I know, if I was still in charge, how I would tackle that. Because you need the throughput, you need to go fast, but you don't want people to have an easy way of cheating either.
Okay. What is the definition for adults living in congregate settings?
So that is basically, because that's not nursing home and assisted living. What that means is, good question. What that means is prison inmates from the correctional facilities, so jails and the Arizona Department of Correction, and people who have developmental disabilities that are living in like group homes. So it's DD group homes and prisons and jails.
Okay, perfect. So, question back, since the since the mRNA vaccines cause the body to make the protein that the body reacts to, is there any increased risk of the autoimmune reaction? Would a person's body overgeneralize its immune response from the protein to the human cells that made the protein?
So the answer to that is, at least so far in phase 3 clinical trials, those have not been observed as problems. But remember, it's just, all we have so far are data, about 90 days worth of data from phase 3 clinical trials. And these clinical trials go on for 2 years. So you make a decision after 60 days about whether to authorize emergency use of these vaccines, but the clinical trials go on for years. And so the answer to that question will come in 2022, let's say, where we will, if that does occur, they'll be able to identify it among the participants in the phase 3 clinical trials. Plus, there is, and there's a whole different PowerPoint that I have on this topic, but that is that there is there's a whole surveillance system in place for normal vaccines, where they look for adverse events once they've been deployed out to the general population. And for these vaccines, there's not just one process, but there's like 4 different processes that are underway to identify longer term or even shorter term adverse events. Because you could think of, in a way, you could think of what we're doing right now as phase 4 clinical trial, because people are getting vaccinated right now as we speak. Now there's no placebo groups, but people are out there getting the vaccine, and there are systems in place to identify and track whether there are adverse events, including the one that you described around autoimmune disease. But these are all really good questions.
If the Pfizer and Moderna vaccines are the first mRNA vaccines approved for humans, but they have been used for coronaviruses that can cause organ failure, is that are both of those statements accurate?
So the mRNA vaccines are the first that have been ever used. So these messenger RNA vaccines that's the first time that I know of that this technology has been used to make a vaccine. So this is the first time this technology has been used that I know of.
I'm sorry. I'm the asker of that question. If I may clarify, or that was actually a comment when you were talking about the mRNA vaccines. They have been used in animals before. I think I may have forgot to mention that word.
Okay.
Yeah. So they have been used actually coincidentally for different coronaviruses that can cause like organ failure in different animals. And source on that is that my sister is a vet, so she knows. I feel like she knows what she's talking about.
Yeah. So you know more about this subject than I do. So there's not much more that I can add on that. But thank you for telling me that, because I did not know. I was been focusing on the human studies. It's the first mRNA vaccines that I've known in humans, but apparently, I guess there have been ones that have used in vets, other animals. Mm-hmm. I just wasn't aware of those. So thanks you for that.
Mm-hmm.
Okay. Next question. Can you say a few words about the availability of funding at the state and local governmental levels? Is there enough funding to expect an efficient rollout of these vaccines?
The answer to that is a resounding yes. You're probably surprised to hear me say that. Here's the problem, and Roxanne, you've seen this. We saw this our entire career, which is that in order to have an effective rollout of a vaccine, you've got to have talented staff that are seasoned and experienced. And one of the things that I have seen over and over in public health is that our state is always starved for public health dollars. Basically, there's no investment of state funds in public health. All the public health, virtually all of the public health money that is in Arizona comes from the federal government. So grants from Health Resources Service Administration, or HRSA, CDC, USDA, that's the WIC program. And so the federal government is really is who pays for public health in Arizona. And what that means is that Arizona has no state-based money, except for some money that comes in from lottery because of voter initiatives and stuff. But we are always chronically starved for funds at the state level, which means the only work we can really do in Arizona is work that's tied specifically to federal grant deliverables. And what that does is leave you in a situation where you're unable to recruit the kind of and train the kind of staff that you need to make good decisions to actually execute when you have a public health emergency. And what happens is a public health emergency occurs, and then truckloads of money start coming to the state, to deal with the problem. I saw it with H1N1 in 2009. We had no money, and then suddenly far more money than we knew what to do with. A few years later with Ebola, same thing. Way more money than we could ever possibly use effectively. And that's what's happening now, is that the state health department, and it's not all just funding problem. And I'm going to just say it. Part of this is on the fact that the governor, when he ran back for office in 2014, his commitment was to cut the size of government by 40% by the time he left office. And he's following through on that promise. And so each of these state agencies, including the state health department, have been on what's called a head count ratchet down system, where the number of FTEs that you have goes down every single year, regardless of how much money that you can pull down in federal grants and so forth. Every year you have to have fewer and fewer staff. And so by design, Our state agencies have been starved for talent, people, and resources, and it's run off talented people like Roxanne and others, because it's created an intolerable environment in state government in which you are forced to continually cut what you do and how you do it. And it is Douglas A. Ducey that's responsible for that policy decision. And this is probably not a political group, but I'm just saying, it's not just money, it's the people in charge that matter too. And he has, by design, cut the size of state government, and it is affecting the response. And so when we see the ineffective response, much of it has to do with the fact that there just aren't enough people that are trained and seasoned and talented enough. And quite honestly, the ones that are there aren't being listened to right now. And so that's my diatribe. And by the way, we haven't gotten into why the vaccine rollout has been so slow. And I don't know if you want to spend time on that or do some more questions.
So we have two interaction questions, one regarding a waiting period after a shingles shot, and another being indemnification of liability caused by the vaccine. You want to touch on either of those?
Just real briefly. So for many, many, many years, there's been a system in place. So here's what had happened over time, is that fewer and fewer companies were willing to make vaccines because they were exposed, when there were adverse events, they were exposed to tort liability judgments. And so there was a time about 2004, and actually before that, where most of the companies were getting out of the vaccine business because of fear on those rare adverse events that they would be sued on multi-million-dollar judgments. And so the federal government created a system in which companies pay in as basically insurance into a fund. And then when people sue, when there are adverse events, and they do occur, they're very rare, but when they do occur, then the person would apply to this vaccine fund, and I forgot exactly what it's called. And that is where you would get tort liability judgments coming out using that system. So that's the second question. And the first question on
shingles.
Shingles. I'm not an expert in shingles, but it's a 2-dose series. That's all I know.
Okay.
Except to say I got my first shot and I never went back for my second shot, which is, you're just not supposed to do that.
Okay. Let's see here. Let's talk about why the rollout is so slow.
So, yeah. So, here's the deal. It's not slow everywhere. It's slow depending on who's in charge and the kind of decisions that they're making. So if you look at Pima County, they're doing a really good job. I mean, Pima County's rolling their vaccine out pretty efficiently, whereas in Maricopa County, it has been far less efficient. And one of the things that is the case in Arizona, and is probably the case in most of the country, is that a lot of the decisions around how you roll out the vaccine are made really at the county health department level. And there's a lot of factors that go into that. I am sympathetic to the challenges that Maricopa County has, because they got like 4.5 million people in their county, and which in and of itself poses particular challenges when you compare it to Pima, which is a much more manageable population in terms of numbers and so forth. But Maricopa had a unique problem, and I'll try to summarize it in a nutshell. But basically, the way it worked during phase 1A is that you would go to your county health department and do a pre-screening you go to their website and do a pre-screening to establish that you're a healthcare worker with direct patient care. And then that data gets sent to the Arizona Department of Health Services into their vaccine management program. It's called the VMS. And what was happening for the first 2.5 weeks is that data was being sent to the state computer system, and the state computer system was defective and was not making the appointments properly. And so there were 5 of the mass vaccination sites for the first 3 weeks in Maricopa County, and only 3 of them were really working because the other 2 were run by Dignity and Abrazo hospitals, and they were using the state's computer system to make the appointments, whereas the Honor Health and the Banner Health systems were using their own computer programs to make appointments. So because the state health department's computer program was defective, those two of the 5 mass vaccination sites were basically empty for 2 weeks. And what made me so mad, and I was able to get Ray Stern from the Phoenix New Times to write an article about this. And the reason that motivated me, because Governor Ducey came on the air and blamed Maricopa County for the slow rollout of the vaccine. And in fact, the reason it was slow, the dominant reason that it's been slow, is the state health department, who's run by Dr. Christ, their computer system, they rolled out without any beta testing, and 2 of the 5 sites sat empty for day after day after day. And I just think, look, if you're in a position of authority like that, you should, you have a problem and something goes wrong, you should own it, instead of blaming other people. And that's what he was doing. And it ticked me off. So at least I got it into the New Times. I tried to get it into the Republic, but it was the week before Christmas and New Year's, and I couldn't find any journalists.
Okay. So in respect for everyone's time, I'm going to go ahead and wrap it. If you would like to stay on, we still have a ton of questions, but I'd like to do that off after the stream. So any final words before we wrap up? Any books you'd like to promote? Any websites to find more info or contact information?
I'll just I'll plug my own group, I guess. So I represent the Arizona Public Health Association. We're a 501c3 nonprofit. We were actually established in 1928, so we're one of the oldest nonprofits in the entire state. Our primary goal is public health advocacy and evidence-based practices. We do that through 2 main mechanisms. One is legislative advocacy. So we're down at the state legislature urging the passage of good bills and urging against bad bills. We also, when voter initiatives are at play, we do advocacy for and against those. We were for Prop 208, for example, which was the education funding initiative this year. And then we do what's called administrative advocacy. That's where we try to get state agencies to make better decisions. A lot of times that is where we try to urge access, state Medicaid agency to make better decisions. In the last 8 months, my advocacy has been mostly directed at my former agency, the Department of Health Services, trying to get Dr. Christ, who was one of my deputies for many years, to make better decisions than she has been, and the governor. To some success, not always. And we're at azpha.org. It stands for the Arizona Public Health Association. I've got a blog that I do. I post a new blog just about every day. And so you can follow my blog if you go there as well.
Excellent. Excellent. Thank you. Well, thank you, Will, for bringing this critical information to our community and into the interwebs. As always, if you enjoyed our content, then hit the subscribe button, contribute to our Patreon, become a member of HSGP, or volunteer to make the magic happen. With that, please be well, everybody. Stay safe, take care, and say goodbye, HSGP. Bye.
Bye, Will. Thanks so much.
Okay.